Is he your first one?
Yeah.
Exciting. It's almost as big of a day for you as for him.
I know. And his mom's here from China.
Oh.
Yeah.
Yeah, they probably want you there soon as you're
they
able.
probably wanted me there an hour ago. I'm not even sure what I'm going to do. Just go ask somebody who shows you where to go.
There's the podium at the front, so that's where they will want you. Okay. So you could just go to the podium and they'll do it.
I wore comfortable shoes so I could literally run over there.
Is that 10 o'clock?
It's 10:30 is when it's supposed to start.
Okay. Okay, then you should be fine.
I will make it. It's right over there, I think.
I won't go too long.
You won't go over time.
Do I need to present all the record stuff too?
Yes.
Okay. Okay.
Oh yeah, of course, mostly everybody is from home.
Okay. Okay, I'll see.
Chancellors, yeah, I saw the email too.
I can work from home on a day. Shucks.
So you guys are typically working remotely?
A lot of people, right? You guys?
Pretty mixed. Yeah.
Yeah. Depends. A lot of people work fully remote.
Oh yeah.
Others are in 4 to 5 days a week. Many are 2 to 3.
Okay. All right. Well, we've got 21 online and several of us here with free parking today. Pointing that out to anyone who didn't want to drive in. So this is the Accords Education Seminar Series on statistical methods in pragmatic research. We have a very special guest today who I'll introduce in a moment, but I'm stepping in for Sarah Brewer today, who is our educational coordinator, just to give you some background on the Accords Education Seminar Series. And just an overview of Accords. We're a T3, T4 health services research group supporting investigators across the lifespan. We're a one-stop shop for pragmatic research. We offer consultations, and we have a number of different cores with different specialties and a couple of great fellowship programs. Coming up soon, June 5th and 6th, we have the CopperCon Innovations in Pragmatic Research Methods. What are we calling that? Conference. So please, if you haven't registered for that, sign up for that. It's going to be remote or online this year, so anyone is welcome to join. And now I'm happy to introduce our speaker, Dr. Keith Goldfeld. He's an applied biostatistician focused on health services research, helping collaborators design pragmatic cluster randomized trials. His current collaborative research is in the areas of palliative care, geriatric care, dementia care, and opioid addiction. He is quite interested in simulation tools and has developed SimStudy, an R software package that enables researchers, teachers, and students to easily generate simulated study data for a broad range of study designs. And he is are you an associate professor? Associate professor at NYU, and we are very glad to have him here today. So thank you, Keith.
Thank you.
Didn't take a lot. Thank you.
I know, what a treat.
That's why there's all those
I don't
chairs
think it's
in the
actually
lobby.
there.
Yeah.
I noticed.
Oh, is it?
All right, thank you for that great introduction. And thank you so much for inviting me out here. It's a treat to get out of the city, so New York City, and always great to breathe some fresh air this time of year. I like this audience style here. And thank you for actually having me come here in person. That's kind of a very retro thing. I think it's the first time since like 2018 or something, since one of these things on the road. So I am going to talk to you today about a new trial, a new study that we've undertaken to evaluate several interventions that are addressed towards improving quality of care for patients with dementia and their caregivers, for those patients who are showing up in the emergency department. And I have 4 primary goals here. One is to describe the study, which is in its very early stages. Second, I just wanted to delve a little more into some of the issues that went into the design of the trial, so the Factorial design, and then the Bayesian model that we are using for that study. And then I wanted to end with a description, given all those issue constraints, and how we came up with our sample size. It wasn't clear exactly how we could justify what we were doing. Before I start, just want to say I have, so this is an NIA-funded grant, and I financial or disclosures of conflicts of interest. Also, I just want to say I have new hearing aids in, and I don't know if I'm shouting or mumbling, so if you can't hear me, just tell me. It sounds very weird. So, so I will carry on. Just to give you a little background context, the funding mechanism for this grant is U19, U19, and it was a special notice of award for very large, complicated projects with multiple interventions, complex integrated interventions that may work alone or work together to improve outcomes for any older population. So our study is called ED-LEAD, Emergency Departments Leading the Transformation of Alzheimer's and Dementia Care. And I just want to say that my proudest moment is coming up with that name. As a biostatistician, it was like a very special opportunity. My wife and I were driving upstate New York, and just throwing around things, and just came up. So the goal of ED-LEAD is to improve the care, as I said, to improve the care of both patients living with dementia and their informal caregivers. And so trying to address emergency care needs in the moment as they arrive in the emergency department, but also to improve post-emergency care. And the goal is to provide longer-term connections with community providers and other services to make sure that they're getting care and maybe not showing up in the emergency department in the future if it's not really an appropriate place for them to get care. So this is the target population, patients who show up in the emergency department and their caregivers. We're conducting the study in 80 sites, 80 EDs around the country, in 11 states currently. We are we're still working out exactly who those 80 sites are. We actually have more sites than we need who are interested. So that's a great thing. And we're hoping to expand into the south of the Northwest a little bit to get a little more geographic and population diversity. So, we have a lot of urban sites, rural sites, community centers, academic medical centers. So it's kind of a wide range of sites and populations. So there are 3 interventions as part of this trial. These are the complex and integrated interventions. The first is the emergency care redesign, and that takes place in the emergency room. So when the patient shows up in the emergency department, they will be identified as having dementia, and then the intervention will kick in. So the intervention is comprised mostly of a clinical decision support tool development, training physician and nursing staff, developing protocols, and then a follow-up call with a social worker. So all these things are geared towards assessing the needs of the patient, not just the immediate needs, but the longer-term needs. The second program is a community paramedic-led intervention, which has the same goals. Obviously, that's not taking place in the emergency department. That's taking place after the patient is discharged home. And I forgot to mention that the target population is patients who are discharged home. So anyone who is admitted to the hospital would not, they would experience the first intervention because that's just part of the emergency department protocols, but they would not be eligible for the other 2 interventions. So once the patient is back home, if they are interested in getting the service, there will be a team that will come to their home within 7 days, 7 to 10 days following the emergency visit. And they'll do a home assessment, again, trying to assess their long-term needs and just see what's going on. It's just a more intensive interaction with the patient. And that's just that's a one-time visit. There may be a follow-up, but that's pretty much the intervention. The third intervention is a much longer-term intervention. So this is a 6-month intervention for the patient. Again, if they agree to participate, there will be a centralized nurse within a health system, so not specific to the ED, but it would be specific to a health system that may have multiple EDs in the study. That centralized person would, or that group of nurses would contact the patient within 2 weeks of that visit, do an assessment, and then there would be follow-up calls every month to help with issues that come up and provide intervention. All 3 of these interventions have been tested to some degree by one of the multiple PIs that are in the trial. And I've been involved with 2 of those trials. But they have not been focused on this population. So this is completely new to focus on dementia populations, mostly focused on palliative care. The general study design. So it's a parallel cluster randomized trial. We're using a factorial design. We have 3 interventions, so there's 8 arms in total. So no intervention, the ECR alone, the paramedic alone, the nurse care alone, and then any combination of the pairs or all 3. So there are 80 sites, so 10 in each arm. And just to be clear, a patient, so if a site is randomized to all 3, they could, if they want, receive all 3 interventions. So it's not that the site is, picking and choosing who gets the intervention. It's everybody in that site would be eligible for all the interventions that they've been randomized to. I'm not going to describe this. I just wanted to re-emphasize how complex the interventions are, and to give you a sense of the integration. So obviously, if a site is randomized only for one intervention, there's no integration going on. But if there is someone, if the site is randomized to, ED intervention and a paramedic intervention, then there has to be some, crossover between the two. They have to talk to each other. So in effect, we have 8 or 7 really kind of different interventions going on, because the ECR with the paramedic is going to look different from the ECR alone. So for example, that follow-up call from the ECR may not happen if the paramedic team is going to be going out there anyways. So it's quite
mind-bogglingly complex.
Yeah. So we're in the process of right now optimizing these interventions at 2 of our sites. So at NYU, is one of the main sites, and then at the University of Wisconsin, which is the main site for the paramedic, with the PI for the paramedic. So they're the guinea pigs for this, and so they're working out the issues. And we haven't actually started. This isn't finalized, and we haven't started working with patients yet. So given the complexity of this, we're kind of doing it's not a step wedge trial, it's a parallel cluster randomized trial, but we are doing it in different ways because we just could not implement each of the interventions at 70 sites all at once, because we have to do the clinical decision support development. That's going to be done by each site, each system, probably. And the training, is going to take time as well. So we're phasing it in over 5 waves. So there'll be 16 per wave. So we'll have 2 arms, or 2 sites in each arm in each wave. So that's how we're roll it out. The randomization is a little complicated. We're trying to stratify by health system, by region, by size of hospital, academic versus community medical center. Obviously, we can't stratify on all the variables, so we're going to use some sort of constrained randomization to do that. Overall, you can see the planning period for each site is going to be about 6 months, and then the intervention will run for 6 months at each site. But because the nurse intervention takes 6 months, we're actually those patients will be involved. So that means the site will be involved for a year. So our outcomes, primary outcome is emergency department revisits within 30 days. Yes or no primary outcome. It is, we're also going to look at it at shorter time frames, 14 days, 6 months. We're also going to look at hospitalization within 14 days. Again, these are all patients who have been discharged home. And finally, we're going to look at healthy days at home, which is a measure that tries to take into account hospitalizations, nursing home visits, death. Okay, so now let's get where it gets a little interesting. You guys are all very familiar with this. This is the Pragmatic trial. We're not consenting patients in any of this. So this is kind of being treated as a quality improvement initiative. And these are kinds of standard of care approaches. So they exist out there. So it's not, it just hasn't been focused on this population. So this patients will be told that there's some quality improvement initiative going on, or there's some, we're evaluating this, but they are not consented, and then we're not collecting data from them. We're not even from their EHR. So how are we going to measure the outcomes? Again, Pragmatic, we're going to use Medicare claims data. So this presents a little problem because we're going to identify patients in the Medicare claims who have dementia, and then use their claims data to look at their outcomes. Now, of course, we can't be certain that those patients were actually offered that intervention or certainly we can't be certain they participated, we would never know. But on the identification side, we're going to use the same algorithm that we're using on the Medicare side to identify patients that would be eligible for the, there's always going to be a mismatch, and this is kind of a limitation. So we actually use this approach in another trial we just did. You know, it has, obviously, it has its biases built in, but there's just no way we could have consented all those patients. It's just too hard. All the PIs I work with say they're done with patient recruitment, so this is really the only option, and I'm very happy because then you don't have to worry about you know, recruitment. Of course, we are going to be collecting data as part of the interventions, so the VHR data collected, and those will be collected centrally and used as, you know, we're going to be doing a lot of implementation-based research to evaluate how well the interventions were implemented, and some of the individual interventions have specific questions that they might be able to answer with the VHR data. Okay, so now that's kind of like a big overview of the trial. So now I just wanted to go into a little bit why we went with the factorial design. It's not so obvious. And there are really two rationales for using a factorial design. One is an efficiency argument. So if you're asking a question about each intervention separately, there may be some efficiency from doing a factorial design. And then the second reason, which is clear why we're doing it here, is there's, you know, perhaps a synergistic motivation for doing a factorial design, but you don't really get the efficiencies that you would expect. We hope for. So I'm just going to go through the efficiency argument. To simplify a little bit, I'm going to go with two interventions. So we're really interested in two separate distinct questions about two different interventions, A and B. So is A effective and is B effective? You could do it at least 3 different ways. You could do 2 separate trials. You could do 1 3-arm trial or a factorial design. So if you start with the 2 separate trials, this is where I wanted my pointer, but I guess you guys can see. We have 2 separate trials. So we have a control arm for A, and we have A on the left to answer the question, is A effective? And to answer B effective, we have a separate control arm. And if we assume that there's N patients in each arm, then that's a total, to answer these questions, 2 questions separately, you need 4N. So that's the least efficient approach. So you could do so this is the model, the simple model that you would use. You're interested in estimating tau A and tau B differently. I wrote it here as delta, just because later on the taus and the deltas are different. So, but you can think of the tau here as the effect size of A, and tau B is the effect size of B. Simple. And so I'm assuming that because they're separate questions, you're not interested, you're not worried about multiple testing, because you do, well, in this case, you've done 2 separate trials, so you just carry on. In this case, we do a 3-arm trial, but now we have a single control arm. And we can ask the question, is A different from a single control arm, or is B different from a single control arm? Again, they're two separate questions. I think it's reasonable to not worry about multiple testing in this case as well. And in this case, the model is, you have a single model, but the patient is either in A or B, so you get the same effect. I didn't point out, so we have N in each arm, so we answered the same questions with 3N instead of 4N, so we've done a little better. Finally, we get to the factorial design. So in this case, we get two arms. We can randomize to control, treatment A alone, treatment B alone, or treatment A and B. Again, these are separate questions. We're not assuming that they are at all, the interventions are all related to each other. So we don't expect any interaction. So the treatment effects should be additive in this case. So we can go ahead and estimate the effect of A by looking at the average of the effects of A versus C, A versus the control, or A and B versus B alone. And so if we make that assumption that the treatment effects are additive, that there's no interaction, then we can take that average and we get the same, the correct treatment effect. Same thing for B. So we compare B with control, or we compare A and B together with A alone. So there's our model. Now we have main effects of A and B, and we have an interaction effect. But in this case, we're assuming that interaction is 0. So what happens is we have a model that looks exactly like our 3-arm trial. It's nice, but I forgot to mention the most important point is that we can do this with only 2N, sample 2N. So we've gone from 4N to 2N, and we can answer the same question. So this is where, this is great. This is where we thought we were heading, but that's totally unreal. 2 points is totally, we're not really interested in the questions about the interventions separate and alone from each other. We are interested in the combination of that's the whole point of the complex and integrated study design. Also, this assumption that there's no interaction is totally unreasonable in most cases. So most of the literature on factorial trials is basically, it's really actually impossible to design a trial unless you have really completely different interventions that takes advantage of the efficiencies. So where does that leave us? Well, so now we have the synergistic rationale. So first, we can conduct a factorial design to answer 3 questions. Is A alone effective? Is B alone effective? And is the combination of A and B better than control? It's not entirely where we want to be, but that's the first trial you could do with factorial. So here, this is a 4-arm trial. Now we have N per arm, so we have 4N. So we can, again, this is similar to the 3-arm trial, but now we have this extra question. So is A better than C? We compare. Is B better than C? And is AB better than C? So now we've answered 3 questions with the same sample size that we did with the 2-8 trial. So at least maybe not, I mean, it is slightly more efficient because we would answer questions. And this is the model. So now we have, it's not quite an interaction term. It's just AB is its own intervention. So we're answering the questions about each intervention effect. And again, since these are completely separate questions, again, we don't have to adjust for multiple testing in this case. But this is not really a very interesting question. Of course, we're not just interested in AB versus control. We want to know about AB versus A and AB versus B. In the case of three interventions, it gets more complicated. So now we want to compare, in addition to is A alone effective, is B alone effective? Now we want to ask, is A and B better than C? Or is A and B better than B alone? And A and B better than B alone? And now it's not, but now we have these multiple questions. It's not clear that you can not adjust for multiple testing at this point, because these interventions are not independent anymore. And it's it's a single trial. I think the literature agrees that you really have to adjust for testing. And this is the problem with we have the same sample size, 4n. We're asking a lot of questions, but we're going to be not able to, unless the effect size is very large, not going to be able to identify anything meaningful. So this is the challenge that we had. Like, how do we do this trial? Because we know that it's super difficult to power a trial for interaction effects for two-way, let alone three-way. And we knew roughly we were going to be between 70 and 90. That's big for like a cluster randomized trial, but it's very small for a randomized trial. So that was our challenge. This is the model here. Now that interaction term, we can't assume that it's zero. And there are all sorts of ways you can come up with hypothesis tests that to answer the questions that you're interested in. But again, it's going to be real. You're going to need large sample sizes to do a hypothesis test to make a decision about does this thing work or not. So this is the model for the trial. So this is just what it looks like with 8 arms, 3 interventions. And I'm just showing here the model. It's the outcome is the binary outcome. They have an emergency visit within 30 days. And we're just modeling a just log odds model. And I'm just showing you here the observed data. So we have the outcome. We have the treatment intervention indicator. That's at the site level. We have ED level covariates that we're stratifying on. And then we have small number of patient level covariates that's available in the Medicare data. So Medicare data doesn't have so much. So then the question was, okay, so how can we, this is pretty much what the model needs to be. So how could we justify any sample size to do this? So I'm kind of a little bit down on hypothesis testing generally in these contexts, these pragmatic trials, just because of so many issues I'm sure you've all struggled with. So that's why I turned to suggesting a Bayesian approach. So I just have a little background in sort of Bayesian models, just to kind of provide a little rationale for. So the frequentist notion, you all know this, probability is a limit, just a proportion of events over a very long time period. For a Bayesian view is that probability is more of a measure of belief. I like to think more of it as a measure of uncertainty. And it doesn't make that assumption that you're measuring, that you're conducting a trial over and over again. You're just gathering some information and you're updating your level of uncertainty. So you start out being very uncertain, and then maybe the data gives you some more information, you get a little less uncertain. So, as I just said, the Bayesian model shifts our focus from away from hypothesis testing and decision rules. So, does this thing work? To, okay, what, does it look like it works? Maybe. And again, so the second point is that the Bayesian approach may represent situations where the mechanism generating the data are non-random and poorly understood. So that's like implementation of the interventions is not clear. Like it's going to vary across sites. Even in our trial, it's going to vary later on when somebody else adopts the interventions. So it's not clear that in a frequentist world, like even if you showed that it was effective in one setting, it's necessary to be anywhere else. Now, there's questions of so the big issue around Bayesian modeling is, as we'll see, is the assumption you need to make about prior probability distributions. I don't really think that's an issue because in clinical trials, you tend to use pretty conservative prior assumptions, actually more conservative than the underlying frequentist assumption would be. And those assumptions are effectively, they're shrinking your estimates towards the null. And that's what kind of mitigates any spurious findings. So the more, obviously, the more conservative you are in your prior assumptions, the less power, power, we don't really talk about power in Bayesian analysis, but that kind of restricts your ability to find to reduce your uncertainty enough to believe that it's going to work. All right, so I'm just going to do a little Bayesian theorem here. So we have an outcome. So we have a outcome B that we're interested in. And the Bayesian model, we are conditionally modeling that outcome as a function of some other. Okay. So we have a conditional probability. This is just a simple definition. That's conditional probability. Probability B given A is just the probability of the joint probability divided by probability of A. We can decompose the joint probability into factor it into probability of A given B times probability of B. This is all very abstract. So in our case, our B is our theta, that's our parameter. So we're interested in our probability of our parameter. So that's the strange thing about Bayesian modeling, is that we are now assuming uncertainty about a parameter. The frequentist modeling, we assume that it's fixed. And we would never think of the probability of a parameter in frequentist model. So that's the weird element here. And then the A is the data. So what's the probability of the parameter given the data that we observe? And this is just an extension of the Bayes theorem. That's just it's proportional. I've left out the denominator. It's the probability of the data given the parameter, which should be familiar. That's the likelihood. And then the probability of the parameter, and that's the prior. So that's the problematic part of this. It doesn't really matter. So you're supposed to divide by the probability of observing the data, which is kind of a strange concept, but it doesn't really matter because that's just normalizing it to 1 so that you have a true probability. So you don't have to worry about the probability of data. So this is what we are trying to aim for. So we do have a range. So this is an example using a coin flip. So if our theta is a probability of flipping heads, we can have, and we're doing a little experiment. We're going to flip the coins a number of times, and then we're going to estimate our theta. So in this case, we're starting out with the prior, we have two probability assumptions, prior probability assumptions. The first is a highly skeptical that it's different from 0.5. So we believe pretty strongly that it's 0.5. And the flat line, that's the uniform distribution. That is, we're kind of ambivalent about theta. It could be anything from 0 to 1. So the frequentist model assumes that flat line. That's and so we can see kind of what happens. So if we take that prior assumption, conservative one, that's centered around half, and we do 20 coin flips and we observe 8 heads, 8 successes, we get a likelihood. So the likelihood is just the probability of observing those 8 successes for each level of theta. So that's this likelihood. And frequentist methods, we would just take the maximum of that likelihood and we put a confidence interval over it and we call it a day, which is fine, but especially with a small sample size, that's kind of aggressive. But we're making a pretty strong assumption that we had no belief beforehand, but we mostly do. But with this, if you look at the posterior that comes from this, that's just the base formula. So that's the multiplying the likelihood by the prior. The black curve is now our posterior. So with small number of samples, we think, okay, maybe it's a little less than 0.5, but probably not. So that seems like a pretty good, much better estimate than the maximum likelihood estimate. If we observe 80 out of 200, now we have a much bigger trial, it's more compelling. So now we see that the posterior shifts closer to the maximum. So that's as we would expect. We see more data, it's more compelling. So likewise, if we had the purple is the weaker prior distribution assumption. It's not flat, but it's still much more diffuse. So we're assuming there's more likelihood that more probability that the prior probability that theta is close, could be as small as 0.25 or 0.75. And when we do that, you can see that the posterior is now much more closely centered around the maximum likelihood. And if you use a prior distribution that's just flat, that's uniform, that posterior will be exactly in line with the maximum likelihood. So the point is that if you are conservative in your prior distribution assumption, you may not put yourself in a position of overstating your results. And if you get and the more data you collect, the prior distribution becomes less important. Kind of the data starts to dominate. So now, this is the model. I just wanted to show how we are constructing this in a Bayesian framework. This is the ED lead model. And so we're using a hierarchical structure. And the goal is to kind of constrain the estimates so that we're not finding anything crazy. And so if we start on the bottom, each of those is the prior distribution of the main effects, so the tau A, tau B and tau C alone. And so they all share, the prior distribution shares a common mean. So they're all going to be kind of pulled together. And that common mean is unknown. So in the Bayesian model, you can model that common mean. And that's the top two figures. And that's the prior distribution of that common mean. And as well as the variance of that common mean, how much the taus vary around the tau m. So we can control our estimates by, so right now we're assuming that tau m, the mean, is normally distributed with mean 0 and standard deviation 1. If we narrow that even further, that will constrain the estimates even more. Likewise, we do the same with the two-way interaction terms. So they're also going to be centered around a common mean. And they have that same distribution. But we could have, there are many ways to do this. Like we don't need to, we could constrain each one to be, pretty narrow. And it's not clear that this has major advantages. That was kind of cool. To do it this way, it has, because you're making an assumption that that the treatment effects are kind of randomly pulled from a common distribution. So it's kind of nice. You're not making any presumption about one being better than the other. We're not actually, one of the other nice things about the Bayesian estimation is that you can get estimates for all sorts of quantities. So once you estimate your parameter estimates, you can transform them in any way you want, and then you get posterior distributions of those estimates. So we're not really interested in the taus per se. We're interested in the actual treatment effects of each arm. And so we can get the deltas. That's how the translation of the taus, the deltas. We can get the treatment effect of A, which is just tau A, all the way down to treatment effect of all interventions combined. And we're going to have posterior distributions. And you can also compare across the arm. So we could have if we're interested in comparing ABC versus AC, we can get a posterior distribution of that comparison. Again, we're doing lots of tests. That's problematic, perhaps, but if we constrain our prior assumptions, that will regularize our posterior distribution. And again, the goal isn't to make a decision; it's to see if there's a signal. My PIs might disagree. It's unclear. How much they fully understand that. So I think that's important to make clear. Like what you're doing when you're answering this question. Amazingly, I don't know why there was no comments from the viewers on any of this. I don't know if they didn't understand it, but it's like, oh, whatever. It was very strange. This is as you can imagine, this is a huge grant. And I was a little concerned, presenting this because, it doesn't, it's not clear what you're answering, what kind of question you're answering. This is what I proposed as, this is what we're going to show the world once we're done. So this is how we're going to show the data. This is just the posterior distribution. Each row is one of the arms. So bottom row is A alone, second row is B alone, C alone, then A and B, A and C, B and C, and then all three. And so we would get a picture like this. It looks like, you know, A and B, you know, maybe the strongest intervention. Is it better than A alone or B alone? You know, we would have some clear, you know, we have to do some sort of test, or not test, but we would do posterior distribution of that comparison. Okay, so that's where we ended. So then the question is, how do you set a sample size for this? It's kind of clear. So, of course, I turned to simulation to do this, and the focus was to develop a sample size that gave us a posterior distribution with a small enough variance at a given effect size that we would see some sort of signal. So that was the idea, just to minimize the variance of the posterior distribution. So we assumed that the effect size was log odds ratio, odds ratio was 0.8, the log odds is 0.22. And we wanted to identify standard deviation where the probability of that posterior distribution being less than 0 is pretty big, so 0.95. So that's basically, that's using the 90% credible interval. And so we use simulation to find sample size, that generated this level of variance. So this is just a purely conceptual diagram. So this is posterior distributions centered around the target log odds ratio, showing the variance. So if you look at 0.13, when the standard deviation is 0.13, the posterior is with a 95% probability that the log odds ratio is less than 0 when the standard deviation is 0.13. I can show you that when I can. Yeah. So we generated data for a range of effects, just that one effect size, but for different sample sizes of cluster numbers. And then for each of those data sets, we fit a Bayesian model, and then we recorded the standard deviation for each of those models. So for any particular sample size, I generated 200 data sets in a Bayesian model. So the one downside of a Bayesian model is that it can take a little while to estimate, maybe 10 minutes, 20 minutes, maybe an hour. So if you have 200 of those, and then you have 10 different sample sizes that you're testing, you have 2,000. It can take a very long time. It's very difficult, but fortunately, we're able to use high performance cluster. So something that would take, I calculated, probably 15 days to run. It took about 6 hours. So it's doable, but it's not so doable. And then this is the figure we get. So each of the x-axis is the number of emergency department. That's the sample size assumption. Each of the dots is one data set, and the estimated standard deviation for that data set. So at 48 EDs, we have, you can see that the standard deviation is way above 0.13. And so as we go down, we go up in sample size, we hit our target at 72. But we want to be a little conservative and maybe drop out. Also you run the risk, even at 80, you could have a higher standard deviation. I was pushing for 90, 88, of course, budget issues So that's where we're at. So we have 80 sites we're hoping to get going, and yeah, so that's it. I wanted to thank you. So these are the co-PIs, Josh Chodosh at Brody and NYU. Wendy Shaw is at Wisconsin, and Karita is at Sloan Kettering, and Rebecca is a biostatistician, great biostatistician with me at NYU. I should just say that this study is comprised of 5 cores. So there's an administrative core, a implementation core, a stats core, and then each of the three interventions have its own core. So 6 groups. And oh no! Wow, what happened? So I had the QR code for the website where I've written about this in more detail on my blog, but too bad you can't find it.
We can share it around to our listserv.
Very strange. Okay. Yeah. So thank you.
Few minutes.
Oh, that's...
Is there any?
No, I'm chat right now.
You have a question?
I wanted to ask you, you already mentioned that reviewers ask no questions about this. I was very curious about that, about how the approach had been received from the biostatisticians when they reviewed it.
Yeah, that's the question I had. So it's the grant submission, the initial grant submission was, I think it was like 1,700 pages long. And we didn't initially have all these cores, and they actually, so somehow they didn't, in the initial submission, they didn't see the statistical plan. They said this study has no statistical plan. So I had all of this was in there. And so that's where, we decided this had to be we had to have a core. So with a core, you write a separate grant proposal for the core. So, and they have a separate group that needs to review it.
Mm-hmm.
So it was reviewed the second time, but there was no comment. I mean, there were some comments, related to multiple testing, and but it was just very minor. So I guess they were enthusiastic. In our DSMB, we have actually 2 biostatisticians, and NIA made a point of saying we're not going to re-adjudicate the methods, so don't ask about that. You can offer suggestions, but it's not open for discussion. So they definitely bought into it.
That's
great. That's great, because I think particularly for factorial designs, as you were saying, the power gets so diminished if you look at combinations that you want to test. And to me, it makes a lot of sense. Yeah. So I'm quite. I think it's very nice work.
That's really cool.
I think with their initial notice, I think it was pretty clear that they were looking for something a little different, because this complex and integrated design. So
it serves as a model for how to explain a complex design to a study section that you don't know what their experience is. So there must be something about the way that you.
Yeah, I did basically this. I laid it out pretty.
Well, as a non-statistician, if I could understand it, see.
I was just thinking you probably wrote it very, very well explained, very nicely, that they said, yes, this all makes sense.
Yeah.
Explaining the why and the design choices involved, probably.
I have a question about the simulation part. So did you just assume the same sample size across all the sites?
Yes.
Okay.
Oh, no, actually not. I didn't. I actually varied it.
Okay.
I did. I had a range of small and large.
Okay,
Yeah.
that's great, because
Yeah.
usually if I'm doing something off the shelf for a cluster randomized trial, I make that assumption, even though I know.
Yeah.
I usually go with the smallest possible
Right.
from a single site, but with 80, I'm sure there's
Yeah,
gonna
I mean,
be.
it doesn't actually make a difference in the end.
Yeah.
You know, maybe it increases your variability a little bit, but you know, it's nice to, but I find that it doesn't really matter that much, but yeah, it's nice to say that you were realistic.
And then how does the concept of intercluster correlation factor into that? Just using that model, I guess. Yeah. I mean,
yeah, so I assume, like, so for the variability, I look at the range of probability of outcomes across the sites. So for a given level of variance assumption that I made in the simulation, you can see what the range of outcomes is in a control state. So the ICC in the binary outcome is kind of unclear, like no one really can interpret that. So I like to look at what does that mean in terms of variability and probability across the EDs. And so we actually had numbers to inform that variability. So that's how I targeted I think it's like 30% revisit within 30 days, ranging from like 20% to 40%. So if in the simulated data, that's what it looked like, then that's what I used. But I did assess different levels of variation as well.
Okay, yeah, it's nice that it's not a rare outcome, because that would have been harder.
Yes, no, well,
yeah.
I mean, that was the point, that it was not rare.
Yeah.
So.
Yeah.
Right.
Although sometimes I do studies on rare outcomes.
Right, but they wouldn't spend so much money. They wouldn't
Yeah.
spend so much money trying to figure out how to solve.
That's a good point. Yeah.
All right, it is 10:02, so a little past the hour, but I want to thank Dr. Goldfeld again for doing our last seminar of the year, and for Dr. Colborn for partnering with us for the seminar series. Evaluation link is in the chat, and Sarah sent the blog link in the chat as well, and I'll make sure that gets sent around as well.
Okay.
Thank you.
Thank you.
Thank you all. Yeah.
All right.